Hello everyone, good morning. I welcome you to another lecture on some more miscellaneous points about upper extremity condition. So first let's see about thoracic outlet syndrome. In thoracic outlet syndrome, there is an anatomic variant where there is a cervical rib anomaly. So this is the first cervical rib. So here, since it is the anomalous, then therefore all the neurovascular structures which comes out of it is compressed. So patients will experience paresthesias as well as potential muscle wasting in the affected upper limb areas. There will be paresthesias and potential muscle wasting. It is diagnosed through a physical examination, and while imaging, it is very obvious to visualize the aberrant rib. So how will this knowledge be tested in MLE exams? It is by they will be giving you questions like a 20-year-old male or a female having paresthesias of the hand as well as the forearm. Sometimes, so generally they'll be having paresthesias because of the compression of the neurovascular bundles, which will be exacerbated by wearing backpack for long periods, obviously, isn't it? So when there is a strain wearing a backpack or lifting heavy objects on the back, then the compression is much more severe, thereby the paresthesias or any other symptoms which they would have because of cervical rib gets exacerbated. Now the question wants diagnosis. Answer is thoracic outlet syndrome due to the anomalous cervical rib. So now the second condition that we are going to see about is Quervains tenosynovitis. Even though the name looks quite intimidating, it is a condition that affects the tendons on the thumb side of the wrist. So if you see, these are the tendons that are affected. So it can be inflamed, it can be irritated, and it can be mostly because of any condition which is requiring um, frequent usage of those tendons. So maybe carrying a baby or carrying or a frequent motion of that tendons. So it will result in inflammation or irritation, resulting in Quervains tenosynovitis. This condition will lead to pain, swelling, and difficulty moving the thumb as well as the wrist. So how will one diagnose Quervains? It is that the patient places the thumb inside the palm and they are asked to close the fingers. The examiner then gently deviates the wrist towards the ulnar side. Sharp pain along the radial styloid process confirms the diagnosis of Quervains tenosynovitis. So what is the treatment? Rest is the treatment. But and the activity has to be curbed. The activity which has led to this problem should be reduced, or else thumb spica splint can be done. Ice application can be done. So any conservative measures, or if it is even more severe, in NSAIDs, anti-inflammatory like ibuprofen can be done. Sometimes some advance for some where nothing works. In that case, corticosteroid injections into the tendon sheets can also be done. So mainly the major treatment is but once all that is done, then stretching and the strengthening exercises will restore normal tendon function and it will prevent the recurrence. The other condition is about the scaphoid fracture. What we need to know about a scaphoid fracture is that the scaphoid bone, which is a carpal bone, is present in the anatomical snuff box. So there will be, when there is a pain in the anatomic snuff box, then it is very obvious that the scaphoid is fractured. So it occurs with a fall on outstretched hands. What we need to know about the scaphoid is that it has a unique retrograde blood supply. That means there is, even though during the initial X-ray, the scaphoid fracture will not be obvious, but if there is pain in the anatomic snuff box, then we have to be very clear that it is a scaphoid fracture. So why should we have to be very clear? It is because of this unique retrograde blood supply. If we overlook that the patient anyway is not having any displacement in the x-rays, then and if we miss the scaphoid fracture, then it will result in a high risk of avascular necrosis if that treatment is delayed. So therefore, if we find pain in the anatomic snuff box and even if the x-ray is normal, yeah, even then we have to proceed with the treatment. So the treatment is simple. Immediate thumb spica splinting is enough to restore the blood supply to the scaphoid and to unite the bones. Follow-up X-rays should be performed within 2 to 3 days, and there will be quite an obvious difference. This is about a flexor tendon injuries. So here I want you to know that there are two major tendons, flexor digitorum profundus and flexor digitorum superficialis. So the flexor digitorum profundus is the tendon which will control the distal interphalangeal joint flexion. So usually the distal interphalangeal joints, but whereas the flexor digitorum superficialis will not flex the distal interphalangeal joints, but it is restricted only to the proximal interphalangeal joints. So profundus is the tendon which comes till the distal interphalangeal and causes the contraction of the distal interphalangeal joints. So this is the knowledge which is tested in the exams by these questions. Like a female injured the index finger during softball and they are unable to flex the distal interphalangeal joint. Which tendon do you think is responsible for is injured? Then it is obviously flexor digitorum profundus. And when there is any injury and when we want a preferred donor tendon, palmaris longus is the preferred donor tendon, but the palmaris longus is absent in approximately 14% of the population. Let's come to another condition, which is Dupuytrens contracture. Dupuytrens contracture has a varied etiology. Like Dupuytrens contracture is highly prevalent in those with northeastern ancestry, like Norwegian heritage. They are more prone for Dupuytrens contracture. Alcoholism, chronic alcoholism is associated with increased risk and severity of Dupuytrens contracture. Patients with epilepsy show higher incidence, possibly related to anticonvulsant medications, so they also have Dupuytrens. Diabetic patients have increased risk of developing palmar fascia thickening too. The other condition is ganglion cyst. What is a ganglion cyst? The ganglion cyst is there is a gelatinous collection of joint fluid. So it typically forms an outpouching from the joint capsule or a tendon sheath. Mostly it is located on the dorsum of the hand on the wrist. Sometimes it can occur on the flexor areas as well as on the ankles, but mostly it is on the dorsum. Observation is first line. Needle drainage is indicated only if there is any functional or cosmetic issues. Even if it is drained, there is high chance of recurrences. But sometimes they might ask you like, what if it is not treated at all? What is the outcome of this pathology if it is left untreated? Then the answer is spontaneous regression. With this, we have come to the end of the miscellaneous conditions. So thank you for listening to me all this while. I have an announcement for you. I'm starting my mentoring classes for medical graduates and USMLE aspirants. If you like my videos, if you like my clarity, and if you want to get mentored by me, you can go ahead, send a message in the comments, and I'm looking forward to see you succeed. Have a good day.